Good evening. We're going to present to you our research project, Salu Diagnostics. First, we want to tell you a bit about why we picked this. The two of us are very interested in medicine and biomedical devices, and we decided to work with the Chef Coplius lab at the University of Houston. However, due to limitations because of our age, we could not actually test our device. Instead, we decided to collect our research into a research paper. This video will contain an introduction to types of point-of-care tests and the possibilities of using saliva-based tests to diagnose anemia.
Point-of-care testing is defined by the College of American Pathologists as tests designed to be used at or near the site where the patient is located that do not require permanent dedicated space and that are performed outside the physical facilities of the clinical laboratories.
To be considered a point-of-care test, the World Health Organization requires tests to be affordable, sensitive, specific, user-friendly, rapid and robust, equipment-free, and deliverable.
Point-of-care testing has many benefits, especially in developing nations. Since tests can be performed in one visit, the need for a return visit to receive results is eliminated. Point-of-care tests are also more easily transported, and tests often don't require refrigeration, so they can be efficiently used in the field. Point-of-care tests also tend to be easier to use, so doctors with a high amount of training are not required to be present for the testing. And most importantly, point-of-care testing is affordable, allowing basic healthcare to become more widespread.
The most common point-of-care tests are not saliva-based. In the current market, the most widespread of point-of-care tests include self-monitoring blood glucose meters for diabetic patients and urine-based pregnancy tests. Two major categories of handheld point-of-care tests include dipsticks and immunostrips. Dipsticks, tests that include dipping the test in body serum, can range anywhere from the common pregnancy test to oral or vaginal swabbing. These are used to provide semi-analytical data. Another major category of handheld point-of-care testing is immunostrip sensoring. In this form of testing, a tagging agent is used to show color change or luminescence of a protein antibody. One form of such immunostrip testing includes lateral flow testing, a form of a modified ELISA immunoassay. With improvements in quality control checks and test sensitivity, immunostrip testing and more specifically lateral flow assays have gained traction in the realm of point-of-care testing capabilities.
There are three main methods for saliva collection. The first is using a swab to collect cells from the inside of the mouth. While this method is somewhat reliable, the sample can be contaminated with bacteria from the mouth. The next method is using a substance such as mouthwash to take a sample. The liquid is swished around in the mouth and then collected. However, this method often creates a diluted sample. The last method is the spit method. For this method, patients spit into a collection device and solution is added to stabilize the DNA if needed for testing. This method is the least invasive and usually results in a usable sample.
Currently, the most commercially available of these point-of-care saliva-based tests is the Simple Rapid Test for diagnosing HIV. Simple Rapid Tests are designed for use where a preliminary screening test result is required and are especially useful in resource-limited countries due to their ease of use, fast results, and storage and room temperature. Commercially, the most widely used rapid HIV test is the OraQuick in-home HIV test, an in vitro diagnostic test for detecting HIV-1 and HIV-2 antibodies in saliva. Though these HIV tests are used only for screening large populations and therefore cannot provide quantitative results, the application of simple rapid test processes to detect ferritin levels would therefore diagnose iron deficiency anemia in low-resource settings.
Early point-of-care testing almost exclusively utilized blood samples to screen patients for various diseases. Blood is favorable for the abundance of screenable proteins found within. However, getting these samples can be invasive, unclean, and often require trained professionals. In low-resource settings, these professionals are not always present. A less invasive method that has been tried is finger pricking. This process still takes a blood sample, so the benefits of abundant proteins is still there. However, finger pricking still requires professionals who can properly clean the instruments that are used. Since blood is still being collected, there is still a risk of spreading disease. This is especially dangerous when testing for diseases such as HIV. While finger pricking is likely the best way to obtain blood samples, the future of point-of-care testing may not require blood at all. Saliva samples are taken non-invasively and contain many diagnostic analytes found in blood. Some proteins found in saliva come exclusively from the salivary glands and aren't present in blood. Using saliva also reduces the risk of spreading disease to other patients or those administering the test. This lowered risk portends to easier disposal. Saliva also provides the possibility for the future widespread diagnosis of diseases that require identification of specific molecules in DNA. This identification typically requires cell lysis, protein isolation, enrichment, and purification. While this process often requires a lab on a chip could allow this process to be adapted into a point-of-care process. These DNA markers are prevalent in saliva, so blood samples could be avoided altogether. The major flaw in the use of saliva is that there is a lower concentration of many diagnostic analytes that are found in blood. As seen in this chart, the concentration of almost all of the analytes is lower in saliva than in blood.
In some cases, saliva provides unique opportunities to boost the effectivity of screening methods. The chart shown here highlights some of these opportunities, such as a less invasive, faster HIV diagnostic test and a less invasive method of detecting breast cancer. Anemia is a condition where the body does not have enough red blood cells to allow blood to adequately transport oxygen. This lack of hemoglobin causes an insufficient amount of oxygen in circulation, leading to symptoms such as weakness, fatigue, shortness of breath, chest pain, and dizziness. Anemia can also lead to serious heart and pregnancy complications. Anemia affects about 1/3 of the world's population. However, as shown in this chart, poor rural areas such as countries in Africa are most affected by this condition. According to the World Health Organization, children and expectant mothers are at the greatest risk for complications caused by anemia. When women give birth with undiagnosed anemia, there is a greater chance of prematurity and low birth weight, which can be fatal in the developing world. A lack of iron in the mother can also lead to an iron deficiency in the child, which can stunt growth. Iron deficiency anemia in children can also cause decreased cognitive function, impaired motor development and growth, poor school performance, poor immune function, and susceptibility to infections. Based on the overwhelming number of people who suffer from anemia in the developing world and the devastating consequences this disease can have, we decided to target anemia in our design.
Anemia can be detected through a shortage of the protein ferritin. In steady-state conditions, the serum ferritin level correlates with the total body iron stores. Absence of ferritin is an indication of iron deficiency anemia. Traces of ferritin can be found in the saliva and around the gums in addition to its traditional detection from blood, so the opportunity to use a non-invasive saliva-based test to measure ferritin levels can be capitalized upon.
Paper is an attractive option for point-of-care testing because it is transportable, easy to reproduce, and most importantly, it can greatly reduce the cost of tests. Paper is also favorable because it reduces the need for refrigeration for many parts of the test, which can be hard to find in low-resource settings.
When visiting our mentor Dahlia at the University of Houston, she showed us her test for sickle cell anemia. One of the major problems they faced was the lack of temperature control in the field. By using paper and substituting sodium hydrosulfite with sodium metabisulfite, they were able to adapt their tests to be able to stay at room temperature for over 20 weeks.
The ELISA method is a test commonly used to display the presence of antigens or specific proteins in a serum sample. ELISA tests are valid, reliable options because the results are rapid, consistent, and relatively easy to interpret. The most accurate results have been achieved through the sandwich format, which uses purified, pre-matched capture and detection antibodies. The derived signal provides very accurate, specific information. ELISA protocols begin with a capture antibody coated onto the walls of a microplate. The samples containing the targeted protein, a control, and the unknown drug are putted into these wells. In the first incubation, the protein antigen binds to the capture antibody. After washing the microplates, a detection antibody is added to the wells, which binds to the protein captured in the first incubation. Once the excess detection antibody is removed, the secondary antibody is added and binds to the detection antibody. After incubating for a third time and removing the excess alkaline phosphatase, a BCIP and NBT substrate is added and converted to a detectable form by the enzyme. In many ELISA tests, this detectable form is a black-purple color signal. The intensity of this color is proportional to the concentration of antigen present in the original sample.
We used layers of wax paper and double-sided tape to create the structure of the test, because these materials are inexpensive and easily accessible, and the design is recreatable with a small margin of error. The paper and tape would be cut to funnel outwards from one primary inlet to 4 chambers, each dedicated to one solution. The test paper, a patterned wax paper with a designated area for the test saliva sample and one for a control, would be wedged between the solution chambers in a thicker base paper.
Taking into account the materials we used to make our tests, including wax paper and double-sided tape, the cost of our test comes out to 28 cents per test, well within the World Health Organization's criteria of $10 per test. The future of point-of-care testing holds many possibilities. For our device in particular, we hope to be able to test it on patients as well as using dry, preserved, conjugate antibodies and labels, which would increase the sustainability of our test without refrigeration. We also hope to continue our research in the capabilities of point-of-care testing and to see a shift in the medical field to using these devices to provide healthcare for low-resource areas.